أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. Now, before that, at the end of the session 5, I have told you about the single opacity, which can be classified on the basis of radio density. Maybe, a single opacity can be uniform and it can be non-uniform. The uniform opacity, which can be again been divided into with curve and without curve. Most of these cases are the results of the acute inflammation of the lung. And the second one, which is non-uniform, non-homogeneous radio opacity, can be divided or can be classified into two according to my study. It can be non-reticulated, meaning there is no network. And the extreme example is the air bronchogram pattern, for example. You see in the red leading to the grey hepatization in lobar pneumonia, for example. And a lot of X-rays has been given with the reticulation means network, reticulated opacities. Now, reticulated opacity means that it is the result of the chronic inflammation whatsoever, or autoimmune diseases, or vasculitic phenomena, or those conditions which can lead to the destruction of the lungs, can cause different type of the reticulation. It may be associated with nodular. That is called the reticulonodular pattern. So I'll start with this session number 6, and this means that in section number 6, I want to deal with the multiple opacities. They are classified geometrical opacities, which will be artifacts in plants or foreign bodies. And then non-geometrical opacities, they are classified according to the size of the opacities. If they are just like opacities less than 0.5 millimeter, hardly, you can't see properly, but it can be visualized with the magnifying glass. Miliary opacities, like millets-like opacity, it should be about 1 to 3 millimeter in size mostly. A micronodular is more than 3 to 5 millimeter, and macronodular means that it is more than 5 to 10 millimeter, or some books say it is 15 millimeter. Mixed micronodular opacities, where there are different sizes of opacities, which can be from 10 to 20 millimeter. Cannonball opacities are more than 20 to 25 millimeter. If there is 25 millimeter in diameter and without specific shapes, they are called cannonball opacities. Now, patchy opacities, they are shapeless of the different sizes are seen, just like a patch. And the honeycomb opacities mean that the reticulation now mingled up and forms the combing effects. They are forming the combing effect, they are called honeycomb lungs. Now, these are the geometrical shape, triangular, rectangular, and other than this, you see the different shapes, squares, and so on. Specific shapes are seen. Geometrical shape opacities, multiple nodular opacity. For example, here you see the three opacities here, 1, 2, and 3. Now, foreign body in the esophagus. Here is the gastroesophageal junction. This is the junction part. So here one has engulfed actually what we call the coins. It is psychiatric patient probably. Look at the geometry of the shape of these opacities. Now, the other one is a foreign body, single one. This is entrapped between the outside the pleura, but in the chest wall. This is a bullet, which is seen here. So it is one, although it is one, it may be 2, it may be 3 pellets. The gunshots may be entangled opacities here. It's possibly on the soft tissue shadows. Around here it is possible. I have seen here also previously. Artifacts, man-made. These are the man-made opacities. You see, some radiographer has created it. Or this is the one, and this is the one. These are buttons of the whatever it is seen here, and female do have got the, because of the covering of the breast, they wear the different type of the garments, and these are these two pins, or it may be pins, it may be buttons type of things. Two in number, different sides are seen. These are the artifacts which are entrapped in the X-ray. Actually, they should be removed before taking the X-ray, because if there is any pathology behind it, you cannot detect it properly. Non-geometrical shape opacity, there are specific shapes are seen. Some are linear and some are triple, parallel bars, and etc., etc. Not specific non-geometrical opacities. Now they are classified according to the size of it. This is less than 0.5 millimeter. Hardly you will visualize these small dots are there. Very, very small dots in the middle and the lower lung fields. It can be seen in cases of those people who have got the pneumoconiosis, the first stage of the pneumoconiosis, or those people who are traveling in the desert and they inhaled these small particles, or any other particles in the industries. Very small particles are there, and hardly they are visualized. Here, small one, very small size. More than that, it is about 0.5 millimeter. More than that, is 1 millimeter to 3 meter rather. This is the millets-like opacity, miliary shadowings. And miliary shadowings, again, miliary shadowing can be differentially diagnosed according to what I have told you previously, result of the acute inflammation. It is possible in bronchopneumonia, for example, or in the fungal infection can cause like this, coccidioidomycosis, and the other mycoses as well can cause these type of opacities. Chronic inflammation, one, that is called miliary tuberculosis, is possible. And about the tumors are concerned, secondaries of the lungs can cause miliary shadowings. Other than that, it can be seen in the allergic conditions as well, like centric allergic alveolitis can cause miliary shadowings. Another one, the interstitial lung diseases can cause the shadowings, and sarcoidosis can cause these shadowings in less than 1% of cases. A stage 4 radiological picture of sarcoidosis. Parasitic invasion, anything can cause this? Yes, it is possible. With a reaction to the what is called as the Ascaris lumbricoides, and that is what is known as Loeffler syndrome, can cause these type of opacities. A long list can be made with the miliary shadowings. Micronodular, it is about 5 millimeter to 10 millimeter in sizes. The nodulations are seen in both middle fields and the lower fields. It is the part of the pneumoconiosis, or it is a part of the interstitial lung diseases. Macronodular, if they are more than 10 millimeter, you see the big ones. Again, these are the same one. The cause will be the same. In most of the cases, it are interstitial lung diseases or pneumoconiosis, basically causing the macronodular type of a pattern. It may be mixed, macronodular, macronodular, with reticulation. The reticulonodular pattern is seen as well as the micro and macronodular opacities. It is a case of silicosis. Now, silicosis can cause tuberculosis. So, upper zone is involved here. Possibly he is suffering from silicosis. The most common complication of silicosis is tuberculosis. And then see here that the mixed nodular opacity in these cases is burstosis. Now, the hallmark of this condition is this. If it is localized triangular shape opacity is coming from the lateral wall, it is mesothelioma. But look these patches. Here, where is my marker is visualizing you. Here. These are called the linear opacities, the linear markings of the in asbestosis. These are plaques. These plaques are seen here, you know. These are the fibrous plaques. The cannonball opacities are more than 20-25 millimeter in bundle of opacity they are seen, and it is due to the secondaries in the lungs in most of the cases. The cannonballs, you see, they are mainly present in the one line on the lateral wall. They are in one line, they do not coalesce each other. And the lung parenchyma between these opacities are normal. These are the characteristic feature of cannonballs. There is no differential diagnosis can be made with the cannonball. If seen, everybody will say that it is due to the secondary in the lungs. But one thing is more, you see that the cannonballs are visualizing the lateral chest wall. It is in the linear fashion, and the size is 20 millimeters, more than that, of different shapes and sizes, non-geometrical, and the parenchyma between the opacities, this is normal. Very near to the diagnosis is rheumatoid nodules. This is not nodules. This is not rheumatoid nodules. Here, the different in the pleural nodules, subpleural nodules. The rheumatoid nodule is another differential diagnosis with cannonball, because it is more than 20 millimeter in size, and they are multiple. And peachy opacities are here, you see, patch-like, just like a patch. They are the result of the chronic inflammation only. Tuberculosis can cause it, fungal infection can cause it, interstitial lung diseases causing interstitial pneumonias, resulting in the patchy type of opacities. It will reduce the vital capacity of the lungs. That is a problem. So it is they are causing the restrictive type of lung disease if you go for the pulmonary function test. Now, if the reticulation, they coalesce each other, they forming the honeycombing, just like honeycomb. Look, the reticulations, nodulation, reticulation spaces, just like holes. You see here, holes. Now, this is called honeycombing, which can occur in many conditions. In honeycombing, you see, like for example, in case of the tuberculosis, can cause it. As acute inflammation is concerned, and chronic inflammation, the tuberculosis can cause honeycombing, localized, and fungal infection can cause honeycombing. Extrinsic allergic rhinitis can cause it, honeycombing. No doubt about it. Interstitial lung diseases can cause it. So honeycombing, these are the result of the reticulation, means fibrocepta, they are coalescing each other very near, and they are forming the holes there. So honeycombings are also seen in bronchiectasis, very characteristic honeycombing, localized. So elevated right hemidiaphragm, look, the upper border of the diaphragm on the right side and left side, there is a difference of 2.5 centimeter. If it is more than that, it means elevated right hemidiaphragm. You see here, the dome of the diaphragm, costophrenic angle here, and cardiophrenic angle here. Remember, if this angle is very important. If the pleural effusion or a fluid collected more than 300 ml, that it will be obstructed. If it is more than that, 500 ml, a linear curve may be present, LSS curve, small pleural effusion. If it is more than that, then this will be blocked. This curve is not seen, and that is in condition of more than 1 liter of fluid is present. It means very big space this is. If less than what I said about it is 300 ml is difficult to diagnose, or rather 150 ml you can detect some obstruction. Below that, between 50 to 100 ml you can diagnose by ultrasonography. Less than 50 ml you cannot diagnose. Only one thing can be done, and that is aspiration will confirm it, or your clinical examination can confirm it. Otherwise it cannot. Or HRCT can be done to rule out very small effusion. On the right side you see the flattening here, slightly in dome, dome is curved. Costophrenic angle and the cardiophrenic angle. The cardiophrenic angle is usually blocked by the pericardial fat. So this is the angle where the superior inferior vena cava comes out, making this angle with the dome of the diaphragm. No comment about this X-ray. What is the comment? Below the right dome of the diaphragm there is a air shadow, aerogram. This is due to the rupture of some part of the intestine, which is causing the collection of the air under the right dome of the diaphragm. In the left dome of the diaphragm there is the gastric aerogram. Gas is collecting on the fundus of the stomach, which is normal. Now, chilleratory sign means that in cases of if you remember Morrison pouch, hepatorenal pouch, some intestines actually they herniate through it and it can raise the dome of the diaphragm here, raise it, and there are the air shadows under the dome of the diaphragm, the mixed shadows. So this is called the chilleratory sign. You can remember, it's okay, fine. Elevated left dome of the diaphragm is seen only when the gastric distension is there. And this is reverse of this. It should be high, it should be low. Well, not seen here. It's a reversal pattern. A lot of gases are collected in the fundus. It is called gastric bubble syndrome clinically. Gastric bubble syndrome. This is the end of session 6, in which I have completed the multiple opacities. Geometrical shape opacities, non-geometrical shape opacity. Non-geometrical opacities depending upon the size, as I have already given you. I hope that you have understood this session, although it is not a very, very prolonged session, and it is only the keywords are used by me. I hope that, inshallah, session 7 will be carried on afterwards, and probably some of the people may be benefited. Assalamu alaikum wa rahmatullahi wa barakatuhu. Wa ma alayna illa